case I'm going to present today is a case of chronic distal tibiofibular syndesmosis injury. I reconstructed with autogenous tendon graft. Well, this is a 20-year-old young gentleman who enjoyed good past health. He's a student of a language study. He fell while going down slope in a scooter in 2018 and sustained a fracture subluxation of the ankle. This is an injury film, and we see that there's a post type C fracture of the ankle with subluxation of the ankle joint. Our colleagues performed close reduction and external fixation, and subsequently, the external fixation was converted to internal fixation with two syndesmosis screws for stabilization of the distal tibiofibular syndesmosis. Well, the syndesmosis screw was removed in time. That was about 10 weeks after the initial surgery. But luckily, after removal of the syndesmosis screw, there's a widening of the distal tibiofibular syndesmosis, and was documented that that was unstable on table. The patient has been tried on a period of conservative treatment with a cast and non-weight bearing, but after a few months' time, the patient's symptom did not improve, and he was referred to the foot and ankle clinic. Well, in the foot and ankle clinic, we assessed the patient. We did not find too much difference as compared to the trauma surgeons. However, we found one thing which is in addition is that the patient has generalized ligamentous instability with generalized ligamentous laxity with a Beighton score of 5/9. Well, CT scan further confirmed that there's residual diastasis of the distal tibiofibular syndesmosis. Well, at this moment, we still don't have a weight-bearing CT scan. We don't have further information before the operation and how severe the diastasis of the syndesmosis was. And at that time, we have a bunch of options in mind, including continuation of a conservative treatment. Either we're going to revise a fixation with screw, or we're going to have a tightrope together with revision fixation or reconstruction with ligaments. Well, finally, after discussion with the patient, we go for an arthroscopic debridement of the ankle with synovectomy, and then subsequent revision fixation with a tightrope together with a plantaris tendon ligamentous reconstruction for both the AITFL and the PITFL. Well, this is an intra finding which confirmed the residual diastasis of the distal tibiofibular syndesmosis. And actually, there was totally unstable. We can put in a probe, an arthroscopic probe into the distal tibiofibular syndesmosis while we're performing the arthroscopic surgery. And anyway, after fixation, the ankle was stable, and the range of motion was similar to the pre-op condition with a dorsiflexion of 5 degrees and 50 degrees plantar flexion. Well, this is an intra photo showing how we harvest the plantaris tendon for graft. And this is a plantaris tendon. This shows a sequence of reduction with a bone clamp, and then subsequent stabilization with the tightrope. And we put on plantaris tendon graft through the fibula and then anchor to the tibia. This is a clinical photo showing the plantaris tendon being stabilized with a tenodesis screw at the distal tibia. This shows a sequence of reduction of the distal tibiofibular syndesmosis. We reduce it with a bone clamp, and then we put in plantaris tendon graft, the fibula malleolus, and subsequently stabilize the plantaris tendon graft with two bio-tenodesis screw at the distal tibia. The patient was put on a cast for non-weight bearing in the initial 4 weeks after surgery, and then was changed to partial weight bearing in a short leg walker. It was allowed to start range of motion exercise while he was off the walker when he's not walking. And he was started with full weight bearing walking in the MC walker at about 10 weeks post-op. And the walker was gradually weaned off at about 3 months after surgery. This is a clinical photo which shows that the ankle modus was nicely reduced and the distal tibiofibular syndesmosis was stabilized at 3 months post-op. And the young gentleman actually had returned to college for language study. His ankle was pain-free when was recently assessed. He resumed usual activity without any limitation, and he planned to continue with his master course after graduation from his primary degree. Well, this is a clinical photo at 1 year after surgery, shows no further widening of the ankle syndesmosis. This is the ankle mortise view, which is comparable for both the left and right ankle. This is a clinical photo while he was assessed by us at 2.5 years after surgery. We see that the ankle was, there's no major deformity and the range of motion on both sides are almost the same. Although he still have the persistent generalized ligamentous laxity. Well, just a very brief literature review. Since this is a really rare case that we have encountered, we try to search the literature to see whether there's something which is similar to such a case which was being presented. Well, as a summary, for chronic syndesmosis injury, the surgical management options include distal tibiofibular syndesmosis debridement, syndesmosis screw fixation, suture button repair together with plus or minus tendon graft reconstruction. However, there's no consensus about the kind of treatment that was best in taking care of these kind of injury. Well, there has been comparison for the fixation of the distal tibiofibular syndesmosis with screw or suture button. However, there are not too many research performed on autologous tendon graft reconstruction for distal tibiofibular syndesmosis injuries. And studies of autologous tendon graft reconstruction with distal tibiofibular syndesmosis in patients with generalized ligamentous laxity was even sparse. And I've tried to search very hard in the web and in the literature, and just found one paper which is closely resembled to what happened in our case, which is a paper published by the American Journal of Sports Medicine some years ago, which studied about generalized ligamentous laxity as an independent predictor for poor clinical outcome after the modified Brostrom procedure for chronic lateral ankle instability. And the paper and the authors actually found that patients with generalized ligamentous laxity do experience recurrence of instability even after reconstruction. There are some surgeons try to look into this topic. This is one of the latest journal that I can find in the literature, which is published by a group of surgeons from Shanghai, mainland China, which is a systemic review of a reconstruction of the chronic distal tibiofibular syndesmosis with autologous tendon graft. The authors find 5 papers which meets their criteria after they search quite thoroughly through the database and also through the internet. And among these 5 papers, surgeons use various different tendon graft for reconstruction of the distal tibiofibular syndesmosis, which includes hamstring grafts, the peroneal longus tendon graft, and one of the author actually used a plantaris tendon graft as what we have performed in our case. They assessed the patients and they found that most of the patients after chronic ankle distal tibiofibular syndesmosis injury, if they are left untreated, in the initial phase, the patient will have persistent pain and they will feel instability, and the pain would unresolved even after conservative treatment. And with tendon graft reconstruction, all of the patients improved according to these studies. And they have assessed a patient with various different score systems, like the Carden scores, the AOF-AS score, the VAS pain scale. All they improve as compared to pre-operation after reconstruction. This is a diagrammatic representation of how they put in the tendon graft for reconstruction of the distal tibiofibular ligaments, including the AITFL, the PITFL, and also the interosseous ligament of the syndesmosis. So after reviewing the literature, the authors from Shanghai concluded that reconstruction of the distal tibiofibular syndesmosis with an autogenous tendon graft for chronic ankle syndesmosis injury show good therapeutic effect in terms of both subjective patient symptoms and also objective evaluation scores. And since most of the authors use the interosseous ligament as a target of reconstruction, they propose that the interosseous ligament could be an appropriate reconstruction target in treatment of chronic distal tibiofibular syndesmosis. Okay, this ends my presentation.